in the webinar.
Hello. Terrific. Welcome, everyone. And thank you for coming and joining us for this American Academy of Ophthalmology and CUGH Symposium. Thank you to the CUGH for allowing us to present here today. We are going to focus on eye health. My name is Paul Chan. I'm the Secretary for Global Alliances for the American Academy of Ophthalmology. Here with me today is Vivian Yin from Canada, who will also be co-chairing this session. We're going to have a really terrific session over the next 3 hours with speakers from all around the world. And I think this is one of the beauties of the Zoom and virtual platform. The first session will focus on the burden of blindness on family and society. We have Jennifer Padnick, who's an assistant professor of ophthalmology, ophthalmic epidemiology in the Department of Ophthalmology at the University of Colorado. Her research interest is in disparity in ocular disease in vulnerable populations. We then have Dr. Kevin Frick, who is a professor at Johns Hopkins Carey Business School. His research focuses on cost associated with disease or measuring cost effectiveness of treatment and care systems and community-based interventions. So welcome, Dr. Frick. And also to wrap things up, coming from us from Africa is Dr. Siku Matenge, who is the founder and director of the Rwanda International Institute of Ophthalmology. She's the president, the newest president of the African Ophthalmology Council. And she has many awards and accolades, and recently Vision Excellence Awards by the IAPB. So with that, I'm going to pass it off to Dr. Jennifer Padnick to begin our first talk. Thank you.
Great, thank you. Great, thank you for that introduction. Is that speaker working better now? Okay, sorry about that. Let me share my slides here. All right, thank you all for joining us this morning. It's really my honor to present to you today and be the first presenter among this group of folks. I will be discussing global blindness and visual impairment in general, and then I'll be discussing some research examples with an organization I work with called Orbis. It's a nonprofit organization whose mission is to alleviate global blindness. My name is Jennifer Padnick, and I work at the University of Colorado in the Department of Ophthalmology. I'm an epidemiologist, and just recently in the last 6 years have joined the ophthalmology team. I used to be in public health, and I've been really enjoying learning about eye disease. Just quickly, my financial disclosures, as I mentioned, I'm a consultant to Orbis, and I'll be talking about 2 of our research projects today. I'm also a consultant for Go Check Kids, but that is not related to this presentation, and I have no other financial relationships to disclose. The learning objectives for my 15-minute talk are to describe the epidemiology of global blindness and visual impairment. I'll be talking about the overall burden of disease, and also just a brief overview of some primary eye conditions that we'll be talking about that impact our world globally. And then I'll be also sharing some prevalence rates by geographic region. And then in the second piece of my presentation, I'll be talking about 2 Orbis research projects. Both took place in Bangladesh in 2019. One was among female garment workers, and the other was among male bus drivers. A bunch of these slides, when I'm just talking about the general epidemiology of global ophthalmology, are from the Vision Atlas. So I want to thank them for sharing some beautiful slides. This first one just shows the magnitude of vision loss and vision blindness globally. There are 1.1 billion people with vision loss, and obviously this number is quite huge. There are 2 to 3 billion more people that need ongoing access to services to optimize their vision. And just to put this in some perspective, there are currently 38 million people that are living with HIV. Vision loss will rise to 1.7 billion people by 2050 if we don't make some significant changes in order to change this trajectory. So putting this together in one slide, the number of people with vision loss is growing dramatically. In 1990, we had about 570 million, and in 2050, we're expecting 1.7 billion, so more than a tripling, as you can see. And this is largely due to population growth as well as the aging of our population. So quickly, the most common eye conditions, and I don't want to get into the details here, but I thought it would be good to describe each of the major eye conditions that I'll be talking about, and probably other speakers as well. So cataract is a clouding of the lens, which prevents clear vision and usually progresses to blindness if it's left untreated. The only way to move forward with treatment is through surgery, but it is a quick, easy surgery. But a lot of people worldwide are left untreated. The second condition is age-related macular degeneration, which is also increases with age, as with cataract. And it's a disease affecting the central area of the retina at the back of the eye. The third condition is glaucoma, and this is a group of conditions characterized by the optic nerve damage and visual field loss. This has a little bit earlier onset than cataract and AMD. Diabetic retinopathy damages blood vessels inside the retina, and risk factors include uncontrolled blood sugar, high blood pressure, and high cholesterol. And then the most common eye condition that we all deal with, likely yourself or a family member, is refractive error. And this is when the eye cannot clearly focus on images and it results in blurred vision. There are several different types of refractive error, and they're listed here: presbyopia, hyperopia, myopia, and astigmatism. And you'll probably hear a little bit more about those today. And this is refractive error can basically be fixed with simply a pair of glasses, contact lenses, or a simple surgery. So when we talk about the global burden of disease, the international classification has categorized visual impairment into mild, moderate, severe, or blind. And I don't expect you all to memorize this little chart, but in the US, we usually use 20 feet. So that's the middle column. 20/20 is great vision. Mild impairment is if it's worse than 20/40, but better than 20/70. And then so on until blindness in the US and worldwide is considered if it's worse than 2400. This figure here shows the number of people affected by each of these 5 major eye conditions globally. And this first chart is for all ages in both males and females. The yellow bar represents moderate to severe visual impairment, and the dark orange is blindness. And you can see that refractive error impacts 1.6 million people globally, and cataract is at 100 million. This next chart is the same, but for adults 50 years and older. And you can see here that cataract surpasses refractive error as the #1 cause of visual impairment globally. So going to each of those, refractive error is the largest cause of vision loss, particularly among children. We have 671 million people with vision loss, and refractive error can be vision loss in the near vision, with your near vision, or with your distance vision. And this slide breaks down the number of people. It's 161 million people with distance vision impairment and 510 people with near vision impairment. And again, for these folks, sight can easily be stored with glasses, contact lenses, or refractive surgery. Cataract is the largest cause of blindness and the largest cause of visual impairment among adults 50 years and older. 100 million people have lost vision from cataract. 17 million of these folks are blind, and the sight can easily be restored with a pretty quick surgery. In the United States, cataract surgery is the most common surgery, with over 3 million done annually. I think this slide is the most important, and it's really an astounding statistics, but 90% of vision loss globally is preventable or treatable. Obviously, this gives us hope because there's something that can be done about it, but we really need to get more services out there. Vision loss is driven by inequity, and you'll hear a little bit more about this from other speakers, but 90% of visual impairment occurs in low and middle income countries where access to care is a challenge. And 73% of visual impairment occurs among persons aged 50 years and older. And finally, 55% of people living with vision loss is among females, and CUGH will talk about that a little more today. Vision loss is linked to socioeconomic disadvantage. And this map here shows the prevalence of visual impairment, and it's highest in South Asia and Sub-Saharan Africa. You can see the red, the countries with the red and orange have the highest prevalence rates of almost 18%. And this map here shows pure numbers instead of prevalence rates, and it shows that the numbers are highest in the South Asia region. Moving on to the two Orbis studies that I've collaborated with them on. The first one looks at visual impairment and productivity among female garment workers in Bangladesh. First, I'll start with a little bit of background. Bangladesh is home to the second largest ready-made garment industry in the world, following China. Garment productions account for over 80% of Bangladesh's total export earnings and employs approximately 4 million workers, over half of whom are women. And the nature of tasks involved in the production of garments, such as sewing and cutting, requires very close viewing, which makes good near vision necessary for these workers. Our study objective for this study was Orbis Bangladesh worked with a non-governmental National Women's Development Support Society. Together, they conducted free eye health screening and service delivery for the female garment workers in Bangladesh, and this occurred in 2019. They also provided ocular examinations and glasses to folks who needed it. And the goal was to explore the prevalence of near and correctable distance vision impairment and near vision impairment and associations with income, age, and urban or rural residents. These are our study findings. We had a total of 915 female participants. The average age was about 30. Correctable distance refractive error was present in 29% of workers, and it was similar among urban dwellers and rural dwellers. Just over a quarter of participants, or 27%, had near vision impairment, which is this rate is quite high for this study population with an average age of 30. And the rate of near vision impairment was higher among rural participants at 34% compared to urban residents at 19%. Our final model looked at income as an outcome with near vision as a predictor of income. And we showed that participants with near vision impairment had a lower monthly earning of $6.50 in US dollars. And this was highly significant. This might not seem like a lot in terms of a monthly income for us, but of course over there it's a lot different and can have a big impact. And we concluded that screening and provision of glasses would be a scalable strategy for poverty reduction. In our second study, we looked at visual impairment and risk of self-reported road traffic crashes among bus drivers in Bangladesh. A little bit of background here too. Traffic safety is a major public health concern. Road traffic injuries are the leading global cause of death for persons aged 5 to 29 years old. WHO shows that while traffic deaths are decreasing in higher income countries due to prevention and education and all of that, but these rates are actually increasing in lower and middle income countries. In Bangladesh specifically, the crash rate fatality per capita is very high, and approximately 50% of fatal crashes in the Dhaka metro area involve buses. The objectives for this study, again, was Orbis Bangladesh, together with a local eye hospital in the Dhaka area. We performed eye health screenings among bus drivers, again in 2019. We provided ocular examinations and referral for medications to the local hospital and to receive glasses if needed. The goal was to explore the prevalence and causes of visual impairment among participants and assess associations with self-reported crashes. For this study, we had a total of 700 male participants. The mean age was 42. Having had a road traffic crash in their bus was self-reported among 9% of participants. 18% of participants had presenting visual acuity in the better seeing eye that did not meet the vision standard of Bangladesh for a bus driver, which is 20/30 or worse in the better seeing eye. And for those over 50 years old, the prevalence of visual impairment worse than the standard was almost 30%. We looked at predictors of self-reporting a traffic crash while driving their bus, and near and or distance visual impairment was associated with having had a crash at an odds of 2.5. So we concluded from this study that ensuring vision standards are not only set for licensure, but forced along the way, because obviously you can be screened, just like in the United States, you can be screened and get your license. But then in the United States, 5 to 10 years can pass and your vision might change. So we were just suggesting regularly checking vision. Some final thoughts. These two studies in Bangladesh demonstrate the powerful impact of vision impairment on safety and income potential. Our work at Orbis seeks to improve the well-being of individuals in countries where visual health issues are under-addressed. And Helen Keller has one of my favorite quotes on vision: "The only thing worse than being blind is having sight but no vision." And lastly, as I moved from public health into ophthalmology, I just really noticed the impact that changing vision can have, and improving vision can impact a lot more than eyesight. We need to keep that in mind. Good vision unlocks human potential. Lastly, I want to thank Vision Atlas for their slides. I provided their website here if you want to learn a little bit more. They have a lot of great information on their website. Much appreciation to all the Orbis research staff who helped with these projects. And thank you also to Dr. Malik Kahuk, who is a colleague of mine at the University of Colorado, for helping me with this presentation. Thank you so much for listening to this chat. I want to pass the mic over to Dr. Kevin Frick, who will speak next.
Thank you very much. I will share my slides. There we go. Hopefully those slides are up now. And I'm talking about the burden of blindness on society. And, some of these data we already seen, but just want to re-emphasize the importance of thinking about, oops, sorry, I didn't mean to slide ahead there, but re-emphasizing the importance of some of the numbers that we've already seen. Numbers affected by different types of disease, reminders of all ages, men and women, the different types of disease, how many, and then looking at the distribution globally. We saw a map that showed some of this before, but emphasizing the importance of vision loss by region, and particularly in sub-Saharan Africa, South Asia, and East Asia. And then the numbers that were shown, again, with the movement from about 1.1 billion affected now to 1.8 billion nearly affected in 2050. Okay, so that's just a reminder of what we'd already seen, setting the stage in terms of the numbers. Then, if we want to look at the global economic loss related to vision, that's what we're going to focus on in the next several slides. One of the things that I think is extremely important to recognize as we think about the relationship between economics and ethics is that when I first wrote about this, I talked about the productivity loss from vision impairment and blindness. And someone said there are plenty of people who are blind who are just as productive as people who are fully sighted. So for many years, I've been using the potential productivity loss from vision impairment and blindness, thinking that it would be important to emphasize that not all individuals lose productivity. The problem with that is that using the word from still implies that the blindness or the blind individual is responsible. Since we're talking about this in the context of climate change, and climate change is a societal problem, one thing we could think about is whether we should view the disability and the economic productivity loss that's associated with vision impairment and blindness also as a societal problem. And there's a whole model of disability as a problem for society to solve rather than for individuals to solve. So increasingly, as I work with people on this topic, we're considering rephrasing it as potential productivity loss associated with society's failure to accommodate individuals with vision impairment and blindness. It's a lot more words, but it's also a much better description of where the responsibility for changing the world in a way to help people continue to make a contribution to society through economically productive activities lies. There have been many estimates done in a variety of ways, the most recent of which came from some work that I was involved with, the global economic productivity loss measured with a group that was involved in the global burden of disease measurement. And the number that was estimated was $410 billion globally when we adjust for different purchasing power parity across countries. So basically trying to account for the fact that a dollar can buy more in some countries than in others. The range for an interval around that was from 300 billion to 500 billion. But the key is we're talking about a number in the hundreds of billions. It sounds like a really big number, and it is, but it's also important to recognize that it is less than 1% of the total global gross domestic product. What's critical, though, is to recognize that that less than 1% total isn't equally distributed around the world. One of the main contributors to that is from the relative reduction in employment for people with vision loss. The group that produced the data that was shown in the last slide was looking at all the studies that could be found that talk about reductions in employment for people with vision loss. In high-income countries, we find that there's about a 32% reduction in employment. As you can see, in Central Europe, Eastern Europe, and Central Asia, it's about a 22% reduction in employment, just under 29% in Sub-Saharan Africa, an average of about 30%. Many regions of the world have never had a study in their region looking at how much employment is affected by vision impairment and blindness. And as you can see, only 15 countries even had data on this. So this is an important area. Obviously, we saw some of the work from Orbis, and I'll talk about a different study in my slides. But what's important to recognize is in order to fully appreciate the economic impact of vision impairment and blindness in terms of how it affects employment, how it affects people's ability to contribute through economically productive activities, and how society can make accommodations to help people do that better, it's really important to understand a local context for how much vision impacts employment. When we look at the monetary burden by region, and this is in absolute value, East Asia and South Asia are the highest, followed by high-income North America. Now, that high-income North America isn't the highest because there's a high prevalence in high-income North America. High-income North America is near the top of that list because it has a high value per individual in terms of the loss of economic productivity that's associated with vision impairment and blindness. If we resort the chart, this time not by the absolute value, but by the percent of gross domestic product that is potentially lost due to vision impairment and blindness, you can see that South Asia is still at the top, around 0.6, but then it's closely followed by Latin America, Southeast Asia, East Asia, and now high-income North America comes much further down the chart, and high-income Asia Pacific and Western Europe are at or near the bottom of the chart. So when we think about how to conceptualize the geographic distribution of the burden of a loss of economic productivity, or that potential loss of economic productivity, it's really important to think about, are we looking at absolute amounts or the percent of GDPs, or basically the percent of the economy that's impacted? And I think it's much more important to look at the percent of the economy that's impacted and think about the regions that are at the top of this list as highest priority for new and improved interventions. So that was across all causes. If we zero in and look at the economic burden of myopia, we find that that amounts to about $202 billion in annual global potential productivity loss. And that's from distance vision impairment caused by the refractive error associated with myopia. Now, what's interesting is when we drill down, first we have to come up with the number of people with myopia, and there's been studies that focus on that. And then we are interested in the rate of uncorrected myopia, and there have been a number of studies that have focused on that. But when we think about the overall impact of myopia, we also need to think about how many people with vision impairment associated with myopic macular degeneration. So this is a longer term impact, particularly of high myopia. And one of the reasons that there's such a focus on myopia and high myopia, not just as an individual vision issue, but as a public health problem to be thought about and dealt with around the world. Now, when we take those numbers for the uncorrected refractive error associated with myopia, we have country-specific data, age and urbanization-specific data, and then we use that to feed into the calculation. Same thing coming from the data looking at the macular degeneration related to myopia. And to get to our final estimate of what is the potential economic productivity loss, each of those conditions is associated with the disability weight from the global burden of disease studies. That disability weight is used as a proxy for the percent economic loss related to that individual. We also consider the fact that not everyone in a country is going to be employed, and not everyone in a country is going to be participating in the labor force. But when we assign what's the minimum that we might expect to be associated with this, that goes into the calculation. In addition to the uncorrected refractive error associated with myopia and the myopic macular degeneration, there is also a need to provide care through an informal channel for individuals with vision loss and blindness. And for a long time, there's been an assumption that you would lose 10% of the productivity of an individual with normal vision associated with an individual with blindness, and by extension, a 5% loss for individuals with vision impairment, but not blindness. Those numbers, again, are largely based on assumptions rather than actual data. There have been a very small number of studies looking at the cost of informal care associated with vision impairment and blindness around the world. And that is another fruitful area for research and refinement of what we know to get a better idea of the economic impact of vision impairment and blindness on the family, the community, in addition to the individual when we start looking at productivity loss. We can also look at the per person impact in terms of lost productivity in dollars per capita. And notice that, it's highest in sort of prime age workers in terms of how that gets added up. And we also can look at the lost productivity for all individuals in an age group, also highest in prime age workers. What's interesting is that it has much more of an impact in prime age workers that's much greater than the other age groups, because while myopic macular degeneration may be quite important when it occurs for those at a later age, it is much less prevalent than myopia itself is prevalent. And so those are important considerations as well. And when we look at by region, again, we see East Asia as the region with the highest burden in terms of billions of dollars of potential lost productivity. And we see East Asia, South Asia, and Southeast Asia as the highest when it comes to overall GDP, percent of GDP that's lost due to that. Finally, if we're looking at presbyopia specifically, so near vision issues, there was one study done looking at the value of providing near glasses on productivity among rural Indian tea workers with presbyopia. And what was interesting was the finding that after the study was done, there was almost 85% compliance with wearing glasses. And that there was sort of a before and after. So how much did productivity improve over time among individuals in a control group, and how much did productivity improve over time among individuals who needed the near glasses and were given the near glasses? And it turned out that the group that needed and was wearing the near glasses had the opportunity to gain twice the level of productivity. So just in closing, since we're talking about climate change, it is interesting to think about, and this is not meant to be exhaustive by any means, but different ways in which climate change may impact eye health and might have a long-term impact on the burden that is associated with the economic productivity loss. And just a few things as we think about UV radiation and sun exposure and rates of cataract. And so, as we deal with higher rates of exposure and cataract, how that could affect economic productivity loss, particularly because, as the previous speaker mentioned, unoperated cataract is a very important cause of vision impairment and blindness. Water pollution can lead to several things, including trachoma and irritation of the retina. And then finally, air pollution and dry eye. And dry eye is one that doesn't necessarily lead to vision impairment, but can lead to economic productivity loss in very important ways for individuals who are distracted while they are in the workplace. And with that, I will hand it off to the final speaker for this morning.
Hello everyone, my name is Shiku Mathenge and I am a professor of ophthalmology and director of the Rwanda International Institute of Ophthalmology, and my primary responsibility is to run the only ophthalmology residency program in Rwanda. I'm from Kenya, but I'm married in Rwanda, and my husband John is also an ophthalmologist, and together we run the institute. I'm also a medical advisor for Orbis International, which is a large not-for-profit prevention of blindness organization that's headquartered in New York. My newest position has been becoming the president of the African Ophthalmology Council, which brings together all the ophthalmologists in Africa. And I'm actually very proud to have this role because it's really hard for a woman in Africa to become the president of anything. However, sadly, it is rather easy for a woman to become blind and stay blind. And with that, let's talk about gender and blindness. I do not have any conflict of interest that's relevant to this talk to declare, but I'd like to declare that English is my third language out of the 5 that I speak. Despite that, I'll try and be as clear as possible, and I'll try especially to avoid ophthalmic jargon. So alarm around gender and blindness was raised by a systematic review that was carried out in the year 2000 using data from multiple countries across the world, several Western countries as well as low-income countries in Asia and in Africa. And what it showed is that blindness was 40% more common in women than men. To be old and to be female was especially a double whammy blow. More recently, the Lancet Global Commission on Eye Health revisited the issue and found that in all world regions, as you can see in the graphic on the right, there was an excess of women with both visual impairment and with blindness. Unfortunately, this gap is even worse when we compare girls to boys. So let us look at some reasons why there are more blind women than men. The reasons are both biological and social. Women, like this lady from Nepal here, have specific childbearing roles that put them at risk of diseases like trachoma. Trachoma lives in the eyes of young children, and the women who look after them, cleaning their eyes, are at a higher risk of getting contaminated than men in the same communities. The second lady here, Mrs. Firi from Malawi, her story is rather sad. When she developed a blinding eye condition, she wanted to go to the hospital. She knew where the hospital was, but financially, she was not a decision maker in her family. And the males in her family, specifically her husband, did not see her problem as a priority. She also needed one of them to escort her to the hospital, and no one would. After a few years, her husband died, and only then, after he was out of the way, could she have the right to make her own decision and go to hospital. Of course, we do not want our men to die for us to see, though, but those are some of the challenges that lack of empowerment in women facilitates them staying blind. On the right is Francine. Francine is my patient from Rwanda, and you can see she has bilateral cataracts. When she started going blind from age-related cataract, her community, which loved her greatly, tried to get help for her. They took her to the health facilities, and over 3 visits, they never got any help. Either it was, we don't treat eyes at this facility, you need to go to the next level, and when she went to the next level, the surgeon only visits twice a year and you've come on the wrong day. After 3 such attempts, they gave up. By then, Francine had become completely blind and she could not travel on the back of a motorbike, which is the main form of transport where she lives. So taking her to the hospital became increasingly costly as they now had to hire a taxi. Despite the fact that as a Rwandan widow, she has free medical insurance provided by the government, she found no access to a doctor and therefore no help. The community then decided to organize themselves and to look after her as a blind woman. And they did this for 5 years before we found her and treated her. I'd like to show you a clip of when Francine returned home seeing. And in this clip, it's in Kinyarwanda, so you'll not understand what they're saying. But basically, people are asking her, can you see me? Can you tell me who I am? And who is this one? And as she names everybody correctly, you can see the surprise on their faces, because a lot of people actually do not know that blindness can be reversed. And Francine became a great advocate for eye care and in convincing others to seek help. I'm sure you can all see the joy and the surprise in everybody's face when she returns home, able to see. And in fact, Francine was able to return to her former job as a counselor for genocide survivors in her community. So let us look at solutions that can help us to reduce this high number of blindness in women and solutions that have been tried and that work. One of the things that we can do in reversing the gender inequity in eye care is just to make services more comfortable for women. In some cultures, for example, women cannot wait in the same waiting room as men. They do not feel comfortable wearing the little short dresses we give them as surgical wear before surgery. And in such communities, then having simple solutions like more female professionals to serve them, having something as simple as a separate waiting room, and giving them comfortable, modest theater attire would make women feel more comfortable seeking help for their eye conditions. Empowering women financially is also a powerful solution. This has been seen in models like the Grameen Bank, where Mohammed Yunus, the founder, saw poor women as creditworthy. He had some specific schemes that, for example, provided soft loans to women in order for them to pay for cataract surgery. Microfinance schemes have been shown to make things possible for women. And even though it's not a magic bullet, it helps. And let's look at some of the ways it helps. If we look at this graphic, it shows that microfinance helps women directly and also indirectly. Just being part of a microcredit group bestows a feeling of empowerment and increased social capital. And the improvement in the woman's economic status means that women can make their own health decisions, become less dependent on their spouses for their care decisions. The last possible solution that I'd like to discuss is for governments to ensure that eye health is included in national health financing schemes. This will allow women and other vulnerable people to be able to access services. I live in Rwanda, where we have universal health insurance, and it does cover the cost of most eye surgery. These women on the photo are proudly displaying their insurance cards. I'm sure this contributed to the fact that last year when we analyzed our health data, we found that the number of women attending eye clinics was over 10 percentage points more for women than men. Integrating eye health into the health system and including eye services into finance mechanisms that pool risk certainly eases the financial burden on families. I would like to conclude by saying that we do need to be deliberate in our eye health services, and indeed in all health services, in including specific mechanisms to ensure gender equity. We will not reach universal eye health if we do not facilitate the inclusion of women. Thank you all for listening to me, and feel free to reach out if you have any questions about this session. Reach out too if you wish to support the African Ophthalmology Council and help this first female president become super successful.
Thank you, Dr. Mathanga. It's always wonderful to hear your presentation. And thank you, Dr. Frick and Dr. Padnick, for such wonderful presentation and so informative. We'll move on to the QA portion. I'm going to start the QA session with a question that Dr. Martin has posted in the chat earlier, which is the question of, has these economic burden or impact on, because of vision loss, and the high rate of return, knowing that intervention can really reverse some of these causes of blindness, been presented at the World Economic Forum?
So I don't know for sure that it's been presented at the Economic Forum. I think the key is, for many years we've known about the high potential rate of return. It doesn't cost very much to provide glasses. It doesn't cost very much to do cataract surgery. The key, though, is that we need to have an investment in order to develop a supply chain to get glasses to the areas where they're needed, to have more providers of cataract surgery in the areas where it's most needed, and figuring out the way to motivate that investment now to provide the services to get the economic return has been something that has been a challenge for many, many years, and that we continue to work on, both in academia and many non-governmental organizations trying to advocate for that. And certainly if my colleagues would want to add to that, any other comments would be appreciated.
Dr. Padnick, Dr. Mathanga. Well, I have another question for Dr. Padnick. Well, all of you have shown what an explosion of vision impairments projected to 2050. Is this estimate really secondary to just increased prevalence of eye disease, or is this more an impact of population growth, or a combination?
Yeah, that's a great question. So it's mainly the impact of population growth worldwide, as well as the aging of our population. As we are able to treat chronic diseases and a lot of infectious diseases, people are living a lot longer. And many of these conditions, cataract especially, but AMD, since cataract is the most common, but also AMD, impact older folks. So that's why we're seeing this huge increase.
If I
And
could
the-
add something.
I was going to say, and the only thing that I would, oh, go ahead.
Thank you. Thank you. I was just going to say that, yeah, what Jenna says is absolutely correct. There's also the changing lifestyle, so increase in lifestyle diseases. I remember when I was in medical school, we used to be told, you don't have to worry about diabetes. It doesn't exist in Africa. And now almost in every family, there's somebody with diabetes. So I guess it's a combination of all those things.
And then the only thing that I was going to add was the importance of the near vision impairment, and particularly what that does for a variety of industries that are very common in lower and middle income countries, whether it's the garment production or the tea picker study, or I know a colleague of mine is trying to scope out a coffee bean in production study, and really focusing in on the fact that if we could, get people the glasses that they need for near vision, you can extend their ability to make a much bigger economically productive contribution for a very long time.
And Chiku, just to kind of follow up on what you talked about, the interventions, both to increase access, but also to increase acceptance of eye care for women, both in, Southeast Asia, as well as in Sub-Saharan Africa. These all sounds amazing. And I know that we have nudged the needle a little bit in gender and blindness. Used to be, we say 2/3, and now we're saying 55%. What do you think the global health community needs to do to continue these work and to make sure that we can scale this up for reaching that goal, ambitious goal we have of decreasing burden of blindness by 50%?
Yeah, thanks, Vivian. I think the global community can model this. So within their own organizations, in the way they themselves do things, the way they hire, the way they procure, just by having more women in kind of everywhere, that kind of stimulates women to get the services they need. And sometimes it's in small things like, if an international organization, for example, wants to do research in low-income country, don't hire another high-income country to go and collect data in the low-income country. Support the people within that country to do that work. If you are supporting scholarships, just have a requirement that they should be 50-50 scholarships, not skewed always to one gender. So I guess just by modeling the gender thing within their own organizations, that will trickle down to just women being there and being seen and looking out for each other.
It's definitely a very powerful thing that we have to keep thinking about. There's a question in the chat as well as in QA, and the two kind of link to each other. So I'm going to combine them into one question, and it has to do with this concept that was mentioned earlier by Dr. Frick about the issue of financing and supply chain and trainers. And, we've heard some intervention that works already, but how do we connect the dots, so to speak, on the financing piece with the intervention and supply chain for either medication or for supplies, resource needs in terms of, cataract surgery packs, etc. Any thoughts on that?
So I don't know that there's a perfect answer, and that's one of the reasons that we continue to struggle with this. I think one of the reasons it might be challenging to obtain the financing is the challenge of connecting the dots. So you get the financing, and then you have the supply chain issues, then you have the distribution issues, that last mile type of issues at the the actual implementation. And people who are providing financing are going to want to know that it can get from start to finish, that it is sustainable. And I think that thinking a little bit more broadly about how to make sure that we're building something that's not just intervening now, and when the current set of resources is done, we don't know what to do next. We need to think about building long-term, locally sustainable, locally supported, with obviously help of resources from outside, but really this is only going to function if in the long term it can be supported locally. So it's knowledge transfer, it's wealth transfer, it's implementation transfer. And without that, we won't be able to get the financing, because the financing is just going to look and say, this is only going to last for so long. Why bother making the investment in the first place? So I wish I had an overall answer, but I think the key is that we need to think much more broadly and much more holistically in order to achieve these goals.
Great, thanks, Dr. Frick. I have a couple questions for the group. The first deals with pediatrics, right? So we talked a lot about just the overall global burden of blindness. So, Dr. Padnaik and Dr. Frick, you talked about the numbers. I'd love to get your opinion on just the pediatric burden and how blindness, and in your opinion, how blindness affects that population, including the effect on the social structure. So maybe Jennifer, Dr. Padnaik, you want to take that first, and then Dr. Frick?
Sure, that sounds good. In terms of pediatric visual impairment, I think that obviously education is greatly impacted by if a child has visual impairment, and they're not able to see as well, to read or see the blackboard and all of those issues. And again, a simple pair of glasses can help a lot with that. And it really starts from the basics. Obviously, there are other issues in terms of pediatric ophthalmology, but I think glasses are the main thing that will help with education and then help down the road.
Yeah, I would absolutely agree with that. I mean, we have, even in the United States, we have issues with, the challenges with screening, and then going from screening to making sure the kids get glasses, to making sure the kids keep track of their glasses and don't lose them or don't break them. And so even there, and let alone in other places around the world, how do you make sure you get them, you keep them, you make it socially acceptable to wear them? I mean, it's not nearly as bad as when, some of us who are on this color of an age where it was very stigmatized even in the United States to have glasses at one point in time. But overcoming all of those barriers, and then it can impact not just the child themselves, but the family and others in the classroom. So it has the opportunity not just to have an impact on one person, but on many, if we can improve pediatric, and again, mostly the uncorrected refractive error issue.
Right, and I'm going to shift over to Dr. Mtengue in a second, because the next transition is to her. But we know, there have been reports around children who are blind or visually impaired having half the life expectancy of children who can see, right? And this is historical data. And I in the world that I live in, I deal with a lot of people who are premature and who are neonates, and there's a rising premature population with ROP, and we're seeing this as this epidemic, right? And I think in Africa now, Dr. Mtengue, you are seeing this, whereas about 10 years ago, it wasn't quite the reality yet, but it's truly a reality now. But if you can comment a little bit on your experience with the pediatric burden.
Sure. So for blindness in children is really important for several reasons. One is that when a child goes blind, they have to live with blindness for many more years than if I went blind at this age. So because of that, then we don't want children to go blind. There may not be large numbers of children who go blind, but then in terms of what we call blind years, then it's a lot of years. It's worse in my population where we hardly have any rehabilitation or assistive services for children who go blind. So school almost becomes impossible for them. And as you mentioned with ROP, again, these are conditions that we used to think are not a big priority for us because premature babies didn't survive anyway. So there was no opportunity for them to get that kind of disease. But now, you know, I have been bothering you a lot because we are seeing a lot of ROP in district hospitals, not just in major cities. And these are children who have high potential to go blind, and yet it's a preventable condition. So I think that that's, you know, a new area of focus where a lot of resources will be needed.
Great, thank you. And in terms of interventions, and I know we touched on this a little bit, okay, like what are the top, let's say top 3 things that you all would pick to say, okay, we need to do these 3 things, otherwise we're going to have a problem. But, you know, in addition to that, I want to talk about technology, right? And really this burgeoning, this growth of technology within global eye health interventions, right? And sort of care. And I just want to understand your perspective, you know, each of you, on how are we doing, right? And what's the potential of technological interventions for decreasing this gap, right? This access gap, but also to Dr. Matenge's talk is also decreasing this inequity in terms of the gender gap.
I'll go first just because there's a storm coming and my internet may drop. So as you know, in ophthalmology is a very, I call it a very gadgety field, and really how well you perform depends a lot on the technology you have. And for a long time, there was no equity in terms of availability of different technologies, where you find that people are kind of selective in what they think is appropriate for you. And you know, things are changing. I think Rwanda is going to become the first country in the world to do all their diabetes screening using artificial intelligence, thanks to support from Orbis. And, you know, the world has shrunk and things are becoming very equal. And I think, unfortunately, technology costs a lot of money. So it's hard to bring equity where money is concerned. But like I said, it's all a matter of deliberate effort. I remember when the IOL was invented, it was kind of assumed it will never reach Africa because who's going to buy the microscopes? Who's going to buy the surgical sets? But because, you know, visionaries like Fred Hollows thought we've got to make it happen, it happened. So that's what I mean by just deliberately thinking about how to make technologies available everywhere.
And I too is going to mention artificial intelligence and the importance of it. You know, we have done several studies with Orbis looking at increased productivity with artificial intelligence. Obviously, this technology is still in the early stages, really, of development. We do have an FDA-approved AI system for screening for diabetic retinopathy. And our study shows that you can increase productivity quite a bit. And this will help, especially in areas that are low resource settings. Also, just that we're in the age of communication. And I think we can't discount the benefits of communication as a technology, being able to train folks across the world in this new age, and being able to communicate and ask and answer questions can really help in terms of building capacity.
And the only thing that I would add, I really like the last point about, you know, telehealth applications in addition to the AI. But I think the other thing, obviously, we want to do as much as we can to prevent the development of vision impairment and blindness in the first place. But the technology is increasingly to help with the accommodation and to help individuals who, you know, do have uncorrectable vision problems to be more productive members of society, and how those can permeate and reach disruptive, innovative levels as well, is something that I think is also might be on the horizon, and be able to, as a society, make a bigger difference in the accommodation side as well as the prevention side. So technology across the board can make a big difference.
Yeah, those are all amazing points. And just to follow up on what Dr. Frick had just say, SAVA Canada had a program to train oculoplastic surgeons, a specialty within ophthalmology in Nepal. And that was one of the things we relied on during COVID in terms of training, was a lot of WhatsApp to try to help co-manage very difficult cases, et cetera. So I think technology is not just an application we use just for screening or just for education. It's now permeated through in all aspects to try to really scale up access in every level of care. And we have a great question from the QA asking about any advice from our amazing speakers, how to encourage at a local or state policy level to increase equity in eye health, especially in low-income areas. How do we get buy-in from those who are in the position to change policy?
Again, I will answer it, but with the recognition that we struggle with this mightily and we haven't found the perfect answer. But I do think that I think there's a couple things. One, data to demonstrate just how much inequity there is, as with other inequities that are viewed through a public health lens. Is it by geographic area? Is it by age? Is it by race, ethnicity? Is there some other demographic characteristic to really drive the recognition of what's associated with this, and is it a systemic issue that can be addressed easily through a policy? And then the second thing is more conversations about how little it really can cost, depending on what the main cause is. The relatively small interventions to improve individual with diabetes taking care of themselves, the relatively small amount of money it takes to get a functioning pair of glasses. It may not be the most stylish, it may not be all the bells and whistles of anti-scratch, anti-glare, this, that, the other thing, but a functional pair of glasses is not very expensive. And so what are those simple, tangible, producible steps that don't cost a lot of money, that you can get that investment in the short run and then build a larger public health platform for long-term implementation, where it might cost a little more money, but once you've shown those short-run outcomes and improvements, you can usually get better buy-in after that's happened.
Yeah, I would echo that. And also what Chiku stated earlier, which is really that we need to get females involved, and at every level. So not only as physicians and an ophthalmologist specifically, but as policymakers, in order for policy to change. And I think that's hard. We're seeing that here in the US. I mean, I think getting females involved in policy is going to be a huge challenge, but in order to really, really see change and buy-in, we need to make that happen.
I would add to that, it's easier for eye care to benefit from such policies if there's already an overriding policy at national level. So, I come from Rwanda, where we have the highest percentage of female parliamentarians, for example. And because there's that kind of recognition that there has to be equity at the high level, if you do not have equity in hospitals, in schools, then government asks, what's the problem? Why is it skewed? So it'd be hard for a community as small as the eye care community to advocate hard enough for the agenda issue. But if countries have those policies at government level, then it will trickle down to everything.
Yeah, so Vivian, one of the things I'll say to this, and I'm sure you can add to it, is that so much of what we do depends on good data, right? So if we have good data, if we have good thought out research, we can create arguments to advocate for the people that we're caring for. I'll give you an example. And also things are very financially driven. And I love Dr. Frick's talk, because it really highlights a lot of the things that we do to try to create a clear, rationale around why we're doing certain things and to get government support. In the world that I live in, for ROP care, in many of the countries, and a couple of them I've been to, it wasn't until there was a major medical legal issue in the government hospital that people started to pay attention and say, oh, we better put some resources, or a significant amount of resources, into screening, into caring for this population, into education, right? And to just a holistic approach to caring for these children. Because if one child goes blind, that's one too many, right? From something that is pretty much 100% preventable. So from a data perspective, and I think that this is something that we are doing here, in the US, but also globally, is looking at registries, right? Looking at creating common data models that we can all share, right? In all these funded programs that we're collaborating with. The other part of it is sharing the data, right? We all have to be on the same page so that we can learn from each other and advocate for other places from what we've learned in the programs that we've built, right? So good data will bring good advocacy.
Well said indeed. Thank you everyone for such lively discussion. Any questions from the speakers to each other? Sometimes I know you're holding your burning question till the very end.
I don't have a question, but I just wanted to add, as a person, an epidemiologist coming from public health and moving into ophthalmology, I was in public health for many, many years. And I'm surprised that ophthalmology doesn't have a big seat in public health. It's very rare to come across a state or local health department that addresses ophthalmology, or even a university. And so hats off to you guys for having this session in the first place. I do think visual impairment and blindness is a silent epidemic. And the more we get out there and communicate about it and educate around it, I think that is a huge way to make headway as well. I've just been surprised all that I've learned, and the big impact globally that it has. I think a lot of infectious disease, obviously we just went through COVID, and for that people get scared. It's in the news all the time. People are worried they're going to get it. Whereas blindness and visual impairment, it's not contagious. People just don't think about it as often. And so I think the more we get out there, the more impact that we can have.
I'll add to that, as someone who currently sits in a business school, but started my career in a school of public health and collaborated with people like Dr. West, who's also on, who might also be able to add some insight onto this issue about public health and ophthalmology, that neither in a school of public health nor a business school does one see a lot of this. And thinking about the lens that I have through a business school, what about sustainability? What about innovation? What are the financial incentives or the strategies that we could think about to make it more sustainable, to be able to do that transfer of technology and transfer of wealth and transfer of business models, so that we can think about ways to make this something that is more sustainable around the world, train individuals, have them set up businesses, have them able to make a living by providing eye care services, and think about it from a public health point of view, a business point of view, and a policy point of view. And in my experience, I think the other thing that gets so separated is, the vision is so integral to so much of what we do in life, and doesn't just affect the eye, but it affects your ability to read prescriptions for any disease you may have, or to learn and be productive. And yet we often treat the eye as something that's totally separate from the rest of the body in terms of how we approach it in medical care and in our public health thinking. And so any opportunity that we have to integrate it more into thinking about larger sets of public health issues delivered along with other public health services, and think about the business of eye care alongside the business of public health, I think is just a step in the right direction. So very good point, Dr. Pednick.
Yeah, and thanks for adding it to it. That was beautiful.
Dr. Mathenga, anything to add to that?
No, I think they covered everything very well.
Yeah, I think, just to add to further Dr. Frick's point about, and Dr. Padnick's point about how eye health seems to be in its own silo at time, not really at the main table of global health. I think this format of CUGH has definitely been our attempt to bring eye health into the global health community. And I would say eye health mobilized within itself quite well. So I made a couple of comments earlier about some of the papers Dr. Frick mentioned, that was really a collaboration between multiple different NGOs, multiple different institutions, such as the American Academy, and it's great to see that eye health seem to work really well with each other, but I think maybe they are so happy with each other in our eye world that we tend to not venture out of the eye health world. And that's definitely something I think we have to work more at, integrating into global health instead of just being in our own silo. Any comment on that, Dr. Chen?
Yeah, I do want to say that the ophthalmology community globally has a very strong global health, just community in general, right? And I think that, so many people, when you go back in time, and we've talked about this, for years, that a lot of people thought about ophthalmology and global health as cataract interventions, right? Or refractive error. But if you really think about, so, Dr. Frick and Sheila's here too, people who really made this massive impact on just global health in general is Al Summer, right? And the vitamin A story, right? We forget about that. And Helen Keller, that was one of their main focuses in HKI. So I think ophthalmology has a track record of making impact in the global health arena. I think from a society perspective and a profession perspective, the American Academy, has put a lot of effort and resources into this discussion. We had a task force, as you know, Vivian, you're on it, for academic global ophthalmology to try to bring more awareness to the space. A gentleman named Mitch Brinks out of Oregon actually started, I think, one of the first public health and ophthalmology meetings at OHSU, which is now shifted into this bigger meeting called the Global Ophthalmology Summit. So there's a ton of activity and a ton of interest, right? And I think that this is such a great starting point also, or maybe not a starting point, but a continuation of the work that we're doing in collaborating with the broader community, right? And I think it's up to us and the champions in this field to work closer with our academic institutions and the public health world to bring awareness to this. So, Dr. Frick.
Yeah, I just wanted to add, being a colleague of Dr. Summers, I remember he would always say, if vitamin A only saved eyes and didn't save lives, I might not have been nearly as famous. And it's interesting because that's a perfect quintessential example of the link between ophthalmology and the importance of a micronutrient for ophthalmology with the rest of how it affects health. And whether it's vitamin A, being important for children with diarrhea and dehydration, as well as for eyes, or whether it's AI and the ability to, look at the progression of things related to diabetes through AI having to do with the eye and diabetic retinopathy, or other things where we can, in parallel, say this is happening to the eye and it's associated with this happening to the rest of health. That can help to further integrate eye health care and eye health thinking into the rest of thinking about the health of individuals.
Yeah, absolutely. So well said. Dr. Mathenga, anything you would like to add?
No, I think it's sometimes when we are invited as eye people to other fora in, let's say, in the Ministry of Health here, one of the things that surprises other departments is how organized we are in eye health. We have these strategies, we have ways of working, we are really very organized. We are just bad at linking with other departments, but there's a lot to learn from eye health, even if it's just how well we collaborate, as you said. So yeah, I think there's a lot to do in the future. Thank you.
Beautifully said indeed. I am so grateful to all three of our first set of speakers, Dr. Padnick, Dr. Frick, and Dr. Mathanga. Thank you. And if you can stay on and join even the next QA, we will be very grateful, but I know you all have busy lives, so I totally understand if you cannot. And I'm so excited to introduce the next set of speakers, which are going to be just as informative and triggering of thoughts and discussion as this first three speakers. Our next set of speakers are Dr. Haripriya Aravind, who is the head of cataract surgery and IOL services at Aravind Eye Hospital. Her research interest has been in quality assurances in cataract surgery. She also has many, many accolades and awards for both research as well as for her clinical work, including cataract videos and teaching awards. She also has received the Best Paper Award from the Journal of Cataract and Refractive Surgery in 2019, as well as the American Academy of Achievement Awards in 2019. Our second speaker is Dr. David Chan, who is a clinical professor at UCSF. He is very, very well known in the eye health community and very well published with over 150 peer-reviewed articles. He is also has been recognized widely for his contribution to not just cataract surgery, but ophthalmology, as well as humanitarian efforts by the International Council of Ophthalmology, as well as the American Academy of Ophthalmology. And our third speaker will be Dr. Sheila West, who has been mentioned by Dr. Frick earlier, who is the Vice Chair of Research at Wilmer Eye Institute and the Alma Garbi, if I said that correctly, Professor of Preventative Ophthalmology. Her research has been critical in informing guidelines on trachoma control, which you've heard a little bit about in the previous speaker at the WHO level. We're going to start off this session with Dr. Haripriya. If you want to share your slide.
Thank you so much, Vivian. Is my slide visible? Thank you. Thank you for this opportunity, and thanks to American Academy. So I think we've had some wonderful talks, and now we're just going to be focusing on what we do here at Aravind Eye Care System. So the problem of blindness is huge, with 36 million blind worldwide, and 1/4 of the blind people live in India. And about 200 million others do need eye care. So with this background, Dr. Venkataswamy started the Aravind Eye Care System in 1976 as an 11-bedded eye clinic. And the mission was to eradicate needless blindness by providing compassionate and quality eye care affordable to all. So 47 years later, Aravind is at multiple locations. We have 7 tertiary eye care centers catering to a population of about 1,000 to 2,500 each day. We have 7 secondary eye hospitals, which see about 150 to 400 patients each day. 6 community eye clinics, which are basically clinics run by ophthalmologists, which do not perform surgery. And about 107 vision centers. So on an average, across all of Aravind, Aravind is more in the south of India, in the state of Tamil Nadu, and we have 1 center in the adjacent state of Andhra Pradesh and in Pondicherry. So on any given day, approximately we see about 20,000 outpatient visits, and about 1,900 surgeries are being performed, besides numerous other camps and classes for the residents and the nursing staff. I think one core aspect of what Aravind does is that it is designed for non-customers. It reaches out to people not just who seek eye care on their own, but can we reach those who also need the eye care. So eye camps have been a core of what we do. So besides performing comprehensive eye camps, we also have screening camps for retinopathy, for workplace camps to look for presbyopia. We have camps for school children, and screening of premature babies for any ROP. So we do about 1,200 camps each year, which is helps us see more than 270,000 outpatients and perform more than 100,000 surgeries through these outreach camps. But in spite of these large number of camps performed and large number of patients seen and treated through the camps, we found that only 7% of those who need eye care actually got eye care through these outreach camps. And this was because of a lack of a permanent center in many of these areas. That is what prompted us to think of having vision centers. So these vision centers are permanent centers. We have about 108 centers as of today. And they cater to a population of about 40 to 50,000 people. They are manned by 2 or 3 technicians, and all the patients, however, are seen through online consultation by the ophthalmologist at the base hospital. The measurements are all done by the optometrists and the technicians at the vision centers. So last year, we saw about 720,000 patients through these vision centers. About 90% of the patients were able to provide care at the center itself, and 10% are referred to the larger hospitals, which if they need either any specialty care or surgical intervention. So this slide shows the number of outpatients we have been seeing, the trend over since the inception of the Aravind hospitals. As you can see, we have different streams of people. We have patients who walk in through our camps. We have patients who come in through the walk-in, but to the free hospital where they don't pay for their examination, but they pay a subsidized amount for surgery. So the vision centers, again, steeply subsidized, community center, and the yellow bars are patients who walk into our paying hospitals. So about 45% of the patients, the care is either done for free or at a steeply subsidized price. So about 55% the patient would pay for their care. And the patients who walk into the hospitals, most of the patients don't come in through appointments. So the goal is to be able to provide care to anyone who's at our doorstep. So which means we have to do a lot of planning to be prepared to receive these patients. So some small examples. So one thing is we also have, we have a prediction of how many patients you would be seeing on a specific day. This is based on what your numbers were on the similar day last month, based on the local holidays, the auspicious days. Based on all this, we have the prediction for number of new patients and review patients each day. And we find that at least 90% of the time, we are able to fall within 6 to 7% of what the prediction is. That actually it's that accurate, the prediction. And this helps us to plan our activities, to have our high volume days only focused on patient care, and other days we focus on other aspects like administration, training, and things like that. We also have numerous softwares which help us track the number of patients who enter the hospital real time across the hospital, also at each clinic. So this is one such software, the clinic management system. So again, this is today's data, which shows number of patients seen at one specific point at each of these clinics, a number of patients who have also been seen, and patients who have been waiting for more than 2 hours. So that for these, the EMR number and the ID of these patients would pop up in a different color on the EMR. So we're able to focus on, the patients who have been waiting longer and, give more patient-centric care. We have other small metrics we use as well. One of them is something we call as 0 to 10. The reason this metric was developed was because we find our patient load peaks between 10 to 12 every morning. So we want to ensure that we can send all the patients who are registered before 9 o'clock. If we can send them home by 10, that would free up enough space, enough resources for the patients who would then peak up after 10 o'clock. So because when you have the OP is low, we tend to kind of slow down, but having these kind of metrics make sure that the entire team is geared up to have the resources spared for the peak crowd on any specific day. So putting the patient first is a very integral part of healthcare and eye care. And this value is concerned with the process of answering 2 questions regarding what the patient wants and what the patient needs. So we would like to focus on both of it as ophthalmologists, and also can we do that in a compassionate way and while maintaining the patient's dignity, because like I said, a large number of our patients receive care either free of cost or a subsidized rate, but it's very critical that we treat them with equal or in fact more respect, because we are seeking them out and we reach out to them and we give care. So that's very critical to how we deal with the patients as well. So cost-effective care is also one core value we would like to adhere to. And this would apply to both the hospital as the patient's care. So from the patient's perspective, it is, we not just take into account the amount they would spend on treatment, but also in terms of the time away from their routine work, so loss of wages, and a person accompanying them, travel, etc. So can we focus on reducing return visits? Can we do as much as possible on the same day? Can we reduce their wait time? Can we reduce any unnecessary investigation or treatment? Only focus on what is important. So all of this helps reduce the cost for the patient. And the institution's resources also have to be utilized maximally. So there are numerous innovations which we tried, and one of the one of the aspects which has really helped us is having the two-table system. So with just one surgeon operating on one table and one scrub nurse with one instrument set, I think their productivity is much lesser. But if you could multiply this, if you could have the same surgeon work with one microscope, but two tables and two scrub nurses to assist the surgeon with more number of instrument sets, the number of surgeries performed per hour is greatly increased to about 6 to 8, or even about 10 or 12 for a high volume surgeon. And this makes the surgeon a lot more productive, and the expertise also increases when they perform this high volume. So if you look at the average number of surgeries performed by a surgeon at Aravind, it's about 1,500 per year, which is much higher than the national average of about 200 to 300. And the two-table system is something which has helped us greatly in this. The other important aspect of what we do is how we use our HR. So the backbone of Aravind is our what we call woman power. And our nurses are basically those high school girls whom we recruit from more of the rural areas, semi-urban areas. And they would go through an intense training period for about 2 years. And then we absorb them in the system. So they join us when they're 17, 18, they would get trained till they're 20. And they would work with us for about 3 or 4 years after that until they get married. And maybe longer if they're going to be, settling down close to the hospital. So when we recruit these girls, we look for more of the value fit than the skill fit. And that is how the focus is. And over the 2-year period, we train them intensely, right from the grooming to the clinical skills. All of it is done. So on the same pool of girls, so about 1,000 girls we recruit each year, we train them in different, so after the initial orientation and the overall, overview of eye care, we train them in specific areas, specific skills like in medical records area, refraction, assisting the physician, assisting in OT, performing some of the investigations like HFA, OCT, etc., counseling the patients regarding surgery, pre-op, post-op. So then they are focused in one specific area. And that becomes a huge resource because they tend to excel at what they do. And also before we let them actually work independently, this whole curriculum is, is done such a way that we take them in a very step-by-step process. And before we let them function independently, we also would assess their skill and knowledge at different sites before we can let them actually handle patients independently. So they actually are, the backbone which help the ophthalmologists focus more of their time on the actual diagnosis of the disease and on the surgical aspects and the procedures. This also helps to give us much better or higher quality and productivity and lowers the cost as well. At the same time, the lives of these women are also much better. They're also vastly improved because of this opportunity. So another core pillar of Aravind is the aspect of quality and continuous improvement, which is again very critical considering our high volume system, considering we are at multiple locations and that the patients are from rural areas. So this is a defining character which we would like to focus on. And we have defined very clearly, just for all the staff to understand the importance of patient safety or quality. We are trying to define everything so that everyone understands what we are trying to deal with. Like example, we have these 10 patient safety goals, which are listed so that if there is some incident which happens or any error which happens, we're able to connect it to which safety has been, which goal has been compromised, and what we would have to do to overcome this or reduce this in future. So we also have this incident reporting form, which is on our intranet, and any incident so we encourage the staff to report any kind of errors or anything which would harm the patient or would have compromised the care. So anything from a near miss to a fentanyl event, all of this is reported. So we have about 2,417 incidents reported last year, of which we had about 46 sentinel events. But each of these incidents, and especially the sentinel events, though they are few, it is something which we would like to completely avoid. So each of them we do a detailed root cause analysis. And if you look at one such event, the most common of the sentinel event would be having a wrong IOL power implanted. So we had 13 last year, which is about 1 in 33,000 surgeries, which is again far lesser than what has been reported about. It's about 2 to 5 per 10,000 surgeries in the literature. But I think what helps us to keep our numbers lower, so we want to bring this to a much lower number, is that a root cause analysis of each of these incidents, because it's all internal, will enhance our learning, and we put this back into the system to improve the care. The other aspect of care, besides having very good processes and having the right behavior of the staff, is also measure our outcomes. And one such tool which has helped us to look at the outcomes for cataract surgery is the CUGH tool, where every patient who has had surgery across Aravind, the data is captured onto the software. Today it's been pulled from the EMR, and we're able to analyze the report. So based on different filters, the duration, we can look at aspects of number of surgeries performed, what complications happen, what was the visual outcome post-op day 1, day 30, spherical equivalent, and this could be done for specific IOLs, specific procedures, surgeon groups. And also this could be benchmarked, not just between hospitals, but also between surgeons. So you would know what the average surgeon's complication rate is. You wouldn't know who had the least complication, but you would know what the numbers are like. So all of that helps to, improve quality. And one such factor which we track very closely is our complication rate. So this is the complication rate over the last decade, and with phacoemulsification. So these kind of, looking at data on a frequent basis and having review meetings on a weekly basis with the concerned staff will, help to ensure that we have a plateau and we're able to consistently keep this at an acceptable level. The other aspect, which I think all of us would track, would be our postoperative endophthalmitis. And this slide shows the endophthalmitis rate over the last 11 years. So endophthalmitis rate was about 8 per 10,000 a decade ago. And somewhere around 2014, we started using intracameral moxifloxacin. And after that, we found that the rate of endophthalmitis reduced significantly. And this transition to use intracameral moxifloxacin happened quite quickly because, again, we're able to have the information available. And also, we want to keep Aravind, we want that to be a learning organization which is willing to change and modify its practices if we can improve care. So when we introduced intracameral moxifloxacin in one hospital, we found that this reduced endophthalmitis rate significantly by about 4 times at the Madurai Aravind Hospital. And once we had this data, we had this implemented in all hospitals and in fact in all our intraocular surgeries. And we looked at data over 2 million cataract surgeries, and we found the same reduction of endophthalmitis from 7 to 2 per 10,000, which has greatly improved the care which we can deliver. So I think finally, this model, I think is what makes us special. You know, the aspect we're able to give half our care, half the surgeries or care for free is what is one of our major strengths, because with this aspect, we're able to have better community acceptance. Economies of scale is more possible when doing more free care. Efficiency and high volume is possible, frugality, and the training also get enhanced. And the paying sector also brings in a lot of important strengths for us, like it brings us enough surplus so we can reach out to more people, helps us refine our outcomes, bring in best of technology, and also improve our service quality all the same. So in conclusion, I'd like to quote Dr. V, who always feels that besides having intelligence and capability, what is most critical is to have the joy of doing something beautiful. So thank you, Vivian, and I would like to now invite the next speaker, Dr. David Chang.
All right. Well, good morning. I'm going to follow up on that excellent presentation with a discussion about sustainability. And let me share my screen here. Hopefully we can see that. And I'll move this to the side. All right. Vivian, can you see the slides?
It's great.
All right. So I have no financial interest in global warming or in climate change. So why should we care about our carbon footprint, particularly with our highest volume procedures, such as cataract surgery? Well, first and foremost, although we're specialists, we're also physicians. And we should all be aware that in the middle of the COVID pandemic, the WHO actually declared that it's climate change, not infectious disease, that's the biggest health threat facing humanity. This is a large projection in numbers of annual deaths directly due to impacts of climate change, and this disproportionately will affect poor communities and nations. In ophthalmology, the IAPB has also highlighted how this will impact the delivery of eye care, as well as certain blinding or visual disabling diseases that relate to weather extremes, drought, etc. We are a big part of this problem. All the studies will show that the healthcare system is actually responsible for a large percentage of greenhouse gas emissions. It's highest in the United States, but it's equally high in other industrialized nations. If healthcare itself was a nation, it would be the 5th largest emitter in the world. So this is a big part of this is from the operating room. It's a huge increase during the past decade. We're second in the United States to the food sector for landfill. And a lot of this comes from the operating room. And we know that, our services, our volumes are only going to explode in the next 2 decades with aging of the population. This is a special issue in planetary health from the Royal College of Surgeons in England. And we wrote an article for this highlighting the fact that we have to actually look to low to middle income countries and look at things such as what Aravind is doing if we want to learn to be more efficient and sustainable in our resource use. So we call that frugal innovation. Much of what you just heard from Dr. Haripriya, I highlighted in my ESCRS Ridley lecture when I talked about lessons that we can learn from systems such as at India, where 50 to 60% of their surgery is done for little to no cost. And she just showed you this paper in which we showed the compelling evidence of the benefit of intracameral moxi that she just highlighted. But there's another important conclusion from this paper, because as you've learned, to be initially financially sustainable, Aravind found that they could safely reuse everything on this list. And that enables them to do so much of their surgery for free. You can see they're doing multiple patients in the same operating room. The patients are wearing here their regular street clothes are covered up just with the blanket. So virtually every single one of these would be a violation of what's called an infection control standard in the United States. And our facilities would be shut down for repeated violations of virtually every single one of these. And we can use multi-dose topicals, but many hospitals have rules that forbid that. And certainly we can't have multiple patients in the operating room because of cross-contamination. So knowing this, we should be asking, well, if they're reusing all of this, what is their infection rate? If you take these 2 million surgeries, half of which did not get intracameral moxifloxacin, you get a 4 per 10,000 rate. So this reflects, again, reusing everything. So how much better do we do in the United States where we throw everything out for the sake of infection reduction? Well, we have good data from the IRIS registry, and this is an overlapping period with 8.5 million cases, and it's the same. And surveys would suggest to us that maybe half of US surgeons are using intracameral antibiotics during this period. So it's a very comparable data set, one where we have these strictly enforced single-use mandates, and the other where we know every case involved reuse of multiple supplies and products. And she just showed you that if you use intracameral moxi, then with phaco, you're down about 1 per 10,000. The other piece of this is, what is the carbon footprint of a phaco? Well, in the United Kingdom, it's been calculated to be equivalent to driving an automobile 500 kilometers, roughly 300 plus miles in the US. Contrast that with what's done at Aravind, where their carbon footprint is 1/20th of that. Now, where is the difference? The largest are in the procurement disposal of medical supplies and drugs and pharmaceuticals. So exactly what we were saying in terms of inefficient use of resources where we throw everything out. On the left is my operating room. We're pretty efficient. That's the amount of trash from one day's phaco. This is 93 phacos at Aravind on the right. So you put these two studies together where you find that, we throw everything out, and yet it's not lowering our infection rate relative to when they reuse everything. And yet we're generating 20 times as much of a carbon footprint, largely due to this waste. And you realize that this perception that we have to throw everything out is not only excessive, it's also not, it's not doing any good. Well, we find that actually most surgeons agree that we are excessively wasteful. I co-chair a task force with these 4 societies. OOS is our Outpatient Ambulatory Surgery Society in the US, and that's the Canadian Ophthalmology Society. We decided to do a survey, which we published in 2020, of North American surgeons. And we just published this month in JCRS, using the same survey, European surgeons. So we have, in between these two surveys, 1,500 surgeons completed it. And there's an overwhelming consensus that our trash is excessive. Most surgeons are concerned about climate change. We want more reusable multi-use options. If given the choice and they were the same cost, 10 times as many people would prefer a reusable over a disposable instrument. And we want more discretion to reuse things. So let's look at, opinions about manufacturers. Most agree that they need to consider the environmental impact of both their packaging as well as their products. We want more reusable instruments and supplies as an option, and this should be allowed in their instructions for use. Now, we asked, would you be willing to reuse, or are you reusing topical or intraocular drugs or supply items? So this is very interesting data because 98% said, of course, we can use multi-dose bottles for topical drugs and multiple patients. But look at how few are currently doing so in this column here on the left, less than half. But the same would be true of intraocular drugs, which are not labeled for single use, but most people feel it would be safe to do so. Virtually everyone says you can reuse phaco tips, IA tips, majority IA tubing and irrigation bottles. Most are willing to get rid of a full body drape or not change people in the gowns, and yet you see it's still only about half are doing so. So there are things constraining that. 2 out of 3 feel it's okay to use the same surgical gown on consecutive cases, such as they do at Aravind. So if everyone is in agreement on this, there's such a strong consensus, that begs the question, well, why are we wasting so much? And as I look into that, I think there's a number of reasons. First of all, these infection control guidelines really come from these task forces. In the United States, that would be AORN, which is the nurses, and the CDC. And they come up with recommendations. And so that raises the question of how much of this is evidence-based or is it eminence-based on these so-called expert task forces. So I'll just give you an example. This is the American Instrument Manufacturers Association. And they have these conferences where they sit around looking at ways to maybe come up with ideas to reduce device-related infection. So you're looking at a few number of people, look at the number of people here, and yet 82% felt that, reusable devices are a risk and that reprocessing them is a risk. That instructions for use, IFUs, not being followed is a risk. So out of this comes these so-called recommendations, which I think would be guidance, and they're well intended, but this is our issue. We're not cleaning reusable devices. We're not following the instructions. And so what happens then is regulatory agencies like Medicare take these and decide to enforce them as mandate. So we have these eminence-based policies, but the problem is that they are subjected to bias. And I would submit that if you have a bunch of infection control nurses in a room like this, you've got a biased population. So somewhere along the way, the AORN actually said that we should consider, wear bouffants to cover all your hair and these jackets to cover your arms. And the Joint Commission, as a regulatory agency in the United States, began to enforce this as mandatory. So when they looked at this at Alabama, they found that this is what it cost them for their 34,000 inpatient surgeries to comply with this new mandate, but it made no difference. So in other words, the evidence contradicted this perception that it would be safer. Another problem we have is that if we don't have our own guidelines, then we have to take the recommendations for all of general surgery by default. So a classic example of this, even though short cycle sterilization for consecutive cases is well accepted practice around the world for cataract surgery in 2014, CMS began to enforce the fact that you could not do anything that resembled flash sterilization. And this is where this task force that I was referring to was formed. And we had to do our own studies to validate that you could do unwrapped short cycles that technically we called short cycle sterilization, not flash. And we then developed our own guidelines and published these. These were eventually peer review published in 2018 so that we could defend certain practices where in our sphere of ophthalmology, which I think we all would agree it's different than an orthopedic surgery and general surgery. Another big problem is the manufacturers. You know, what governs their instructions for use, which they have to submit to regulatory agencies in Europe and the US, you know, liability is a factor. Profit is certainly a factor in terms of single use. But a lot of times it's because if you want to say something is reusable, you have to validate for the FDA and repeat all the safety and efficacy studies. It's very expensive. Now, here's the instructions for use for a monofocal lens. And this is for the IOL injector. And these are printed in more than 20 languages with every single unit. So you want to talk about waste. And why aren't they all electronic? Because there are about 50 countries, many of them smaller, that do not accept or allow electronic IFUs. So this is the waste we generate in every case. Is it true that everything in there is evidence-based? Well, definitely not. We actually looked at single versus multi-use phaco tips at the Moran Eye Institute, Nick Mamelis's lab. And in a model found that a tip reused multiple times did not ultrastructurally differ from a brand new tip. So there is no evidence that reusing a tip is dangerous. And yet, because some companies label it as single use and our, you know, health insurance, CMS, Medicare mandates that we follow that, you get into this loop. And then finally, liability governs a lot of decisions in the operating room. And although these, you know, surveys that I showed you are not scientific, I think they do help because, you know, they do show from a community standard standpoint that our peers feel that it is safe to reuse all the items that we discussed. You remember I've highlighted here that throwing out drugs is a huge contributor to the carbon footprint. This is one study that's been published by ophthalmologists that detail the enormous costs of throwing out drugs unnecessarily, but also then quantify the environmental cost of doing that. And it's huge, largely because the life cycle of a drug includes the raw materials needed to produce it, as well as how to dispose of them. Well, we said earlier, well, this is a no-brainer being able to reuse a multi-dose bottle on multiple patients, but I said fewer than half are actually doing that, which is staggering. So we looked at the data and published this follow-up study that if you were at an ambulatory surgery center, you were reusing the drops, but if you were in a hospital, you were throwing them out. This is mostly in the United States, which implies then there's another level of regulations. And so we then focused on a position paper supported by all the major societies that you see here, looking at the evidence, going through with every regulatory agency. Well, why do you have a policy? And if so, can we change it, resulting in this publication and our recommendations that not only can you use multi-dose bottles of multiple patients, you can use it till they expire. And we actually went to Medicare and clarified that you don't have to throw it out after 28 days. What about cross-contamination? You know, we have to do so many things. We have to clean the counters, so-called high-touch areas in between cataract patients. And believe it or not, the anesthesiologist, if you open a vial of a drug, a multi-dose vial in the operating room, you're supposed to throw it out, even though it's a multi-dose vial because of cross-contamination. Well, we learned a lot actually from COVID. There's actually this study, two more that show that it's virtually impossible to aerosolize microorganisms such as viruses from phaco emulsification. After all, there's only 0.2 ml of aqueous and it's quickly irrigated out. And then we did this interesting study at Yerevan that came out of COVID because like everyone, they had to cease all elective surgery. And then when they resumed, they had to think about how to keep everybody safe. So these are the two periods. And some of the things that they did were recommendations from the India equivalent of the academy. And they started, you know, changing gowns in between patients, having patients wear PPE or gowns to the OR, just doing one patient at a time, changing their gloves in between cases, wiping the floors and counters again for cross-contamination. So when you actually collect the data, and this is just all within a year, but again, with their high volume, look at the numbers, you see there's no benefit to these things. So we're over here on the right-hand side, and we could ask the question, if we started doing all these more efficient practices on the left, would it increase our infection rate? And this supports that there's no evidence that it would. Almost everyone wanted their medical societies to advocate for reducing the carbon footprint, and that led to us founding iSustain. iSustain.org is a website, it's an app, and this is now co-sponsored by the 3 major societies that you see here. And it's trying to centralize information, resources, research about sustainability. This actually debuted a year ago at the ASCRS annual meeting on Earth Day. This is the team that we have. I chair the advisory board, but this is the group that launched the website. And what's happened in the years since its launch is that we're happy to now have both ESCRS and the American Academy of Ophthalmology joining us as co-sponsors of this, all 3 societies fully on board with promoting sustainability in our profession. We have now about 24 international global societies that have joined as member societies, including the American Society of Retina Specialists and EU Retina, who are going to work on sustainability in their specialty as well. Our mission is basically to engage and network our community, but also to collaborate with industry on looking for ways to reduce our carbon footprint, to support research, to actually collaborate with other specialties as well. There are many different sections of the iSustain website. We're actually having a new look, and next week will be the new launch of the new version of the website. But this is just the operating room. You can calculate your carbon footprint. All of the task force papers, position statements that I highlighted are readily available. This is the operating room. Each section has key references, because this is what is needed when you want to initiate change in a facility or a country, as you need to have the evidence. This is the whole section on drug waste that we just talked about. And this will be a section where industry talks about some of the things they're doing. At every major meeting since our launch, we've had workshops with industry to discuss ways to collaborate. And I'm very encouraged by how much they are on board with this. So what can we do now? We can already do a number of things. We talked about multi-dose bottles. Don't throw them out after using them in one patient. We can go through our surgical packs, get rid of the things that we're not regularly using. Can immediately eliminate the full body drape and eliminate the patient gown. There is no rule that says this has to be done. You can use short cycle sterilization. Look at things that are reusable, such as diamond versus single use metal blades. Switch to alcohol for hand scrub instead of water-based scrub. And I think most importantly, educate your staff, which you can do through iSustain. This is just one study looking at Bascom Palmer and how much money and water they saved by going this is per OR, by eliminating water-based scrub. This is how we always have draped our patients. We put a blanket over the clothes. The blue drape is not sterile, it's just to absorb water. And we just use a long plastic drape to cover the eye area. A week ago, I have an editorial that you can access. You can take a photo of that title and Google it. It's open access, so you don't have to subscribe to the ASCRS journal. And I kind of put a summary of all the evidence we have in terms of these areas, in terms of why we waste. In an earlier editorial, I made the case that because we have the highest surgical volumes in all of medicine. It gives us both an opportunity and a compelling obligation to lead medicine in terms of making our vital services more financially and environmentally sustainable, following the blueprint that people such as Aravind have given us. So thank you very much. And Vivian, do you want to do the next introduction? I assume you're doing the talks before the discussion.
So I'm going to pass the virtual microphone to Dr. Sheila West. Sheila, just unmute yourself.
Here I am. Thank you. I'm Sheila West. I'm an epidemiologist by training with a career that spans many areas of public health, but most of it I've spent in ophthalmology. Today I'm going to talk about the gap between public health research, and I'm going to share my screen here. Let me do that. And let me pull up my slides here. Somehow my slides closed. Let me, sorry. I'm trying to find where I put some. Here we go. Okay. Can you see the slides now? Vivian?
No, not yet.
Oh. I wonder.
What we can do is Anna Marie can pull up your slides for you.
We can do that. Here we go. All right, and I can change them, I presume. Well, thank you. Sorry for the trying to do this in an environment that isn't very conducive to Zoom. I'm going to talk about the gap between public health research, which should be closest to translational policy, and some of the issues of why it is not, drawing on several examples, but mostly from ophthalmology. I have no financial conflicts to disclose. And actually, this talk follows very nicely on what David was talking about, that gap of what we know and why it isn't policy. So next slide, I'm going to talk about, you maybe have to change these. Yeah, thank you. A spectacular failure, a couple of successes, and an example of a current gap. Next slide. Arguably, one of the most spectacular failures in public health is the almost 80-year gap now between knowledge about health risks of smoking cigarettes and an effective policy. Knowledge of health risks dates back to the 1930s, when an extensive article reviewed the relationship between smoking and lung cancer. That work did not stop the American Red Cross from handing out cigarettes to World War II Army personnel, supplied, of course, by the tobacco industry. That study followed a set of landmark epidemiologic studies linking smoking and lung cancer. And then the president of the American Cancer Society in 1954 wrote a book, Smoking and Cancer, which clearly laid out the facts at the time. And it was actually vilified by the American Public Health Association as non-scientific. Next. 10 years later, the Surgeon General finally issued a report on smoking and its link to lung cancer. Next, this was quickly followed by Congress requiring health warnings on cigarette packages. Next, and Congress banning cigarette ads on television and radio. Next, nevertheless, the tobacco industry ran ads for cigarettes in magazines like Time and Ms. and Rolling Stone, and bought major sponsorship at sporting events like the Marlboro Indy 500. So although they were prohibited from ads, the industry had de facto free advertising through high-profile television programming. Next. So overall, despite a relatively weak but present policy, still almost 13% of adults in the US age 18 and older smoke. An estimated 1.2 billion worldwide smoke, causing an estimated 7 million deaths. Each day, an estimated 1,600 youths try their first cigarette. We are not stopping incident smoking. Next. So why did research and subsequent policy fail to control smoking? Largely because they had a tremendous adversary in the tobacco industry, whose power, money, resources were able to buy organized medicine and many political figures and agencies that weakened attempts at stringent control. Next, as one epidemiologist said, the story of smoking and attempts to communicate health risks require a sober reflection on missed opportunities to do more. So there's a failure. But industry need not be an adversary, but a strong partner. And I've chosen an example of success to illustrate an effective public-private partnership. The example is trachoma. It's an infective eye disease, and I'm going to give you a little bit of background so you understand the importance of what I will be telling you. It's caused by repeated ocular infection with chlamydia. It's the leading infectious cause of blindness. These repeated infections cycle through children, and they are transmitted from person to person. There's no intermediate mosquito or worm or vector. So years of these repeated infections in childhood can result eventually in adulthood in these interned eyelashes. You can see the picture there on the right. And these interned eyelashes damage the cornea, leading to vision loss in adults. Trachoma affects the most disadvantaged communities, and women are 2 to 4 times as likely to have vision loss from trachoma. Next slide. Research has identified a multi-pronged approach to the elimination of trachoma that goes by the acronym of SAFE: surgery, antibiotics, face washing, and environmental change, the latter of which interrupts and sustainably reduces transmission. Next, but I want to focus on the antibiotic, or the A, for just a minute. Next, in the 1990s, an estimated 1.5 billion people were at risk of trachoma, and at that time, the only antibiotic feasible to use was topical tetracycline because of the side effects and cost of oral medication. But topical tetracycline had to be administered twice a day for 4 to 6 weeks, and you can imagine the compliance levels with that. And then Pfizer created azithromycin, and this was a real game changer. It had high intracellular levels, meaning that chlamydia could be cured with a single oral dose treatment. However, Pfizer had concerns for using it as a mass drug administration in districts. Quite reasonable concerns for side effects, concerns for compliance, and concern for use for other reasons. Next. A clinical trial, though, showed that community-wide treatment was highly effective. It reduced, in fact, almost eliminated infection out to 1 year. There were minimal side effects. Community acceptance was very high. This clinical trial led to the beginning of a massive donation program to countries endemic for trachoma. Next. Currently, mass treatment with azithromycin is offered if trachoma prevalence is more than 5% at district levels, and the annual mass drug administration increases the number of years depending on the endemicity. To date, more than 1 billion doses of azithromycin have been donated by Pfizer for country programs. Most of it goes to Africa. This donation has resulted in a high degree of success combined with the full SAFE strategy, and it is currently the standard for country elimination programs. But this would not have been possible without another critical partner. Next. And that critical partner was the World Health Organization. Next. Effective partnership with the World Health Organization allowed for rapid translation of public health research into guidelines for country elimination. WHO helped produce program materials for implementation. An example is shown here with a manual for effective trichiasis surgery. WHO is a trusted source for countries, which again ensured rapid implementation. But it's also important to stress that the research was directed at critical questions for country programs. So the combination of research to answer critical questions, coupled with a massive donation program, coupled with rapid translation of research findings into guidelines and policies, what is making this elimination program effective and likely to reach its goal by 2030. Next. So now I want to talk about a gap where there is effective research that could lead to policy change, and yet there were significant delays. And this parallels very nicely with what David just talked about. But, and again, using cataract surgery, the removal of the cloudy lens in the eye, it's performed in outpatient settings, minimal sedation and use of local anesthesia. It's considered minimal risk surgery. Dental surgery, colonoscopies carry far more risk. 23 years ago, though, preoperative medical history, physical, lab testing was often required. Next. Then in 2000, research showed there was little value in routine pre-op medical testing before cataract surgery, and that testing incurred substantial cost for insurance companies and the Medicare system. However, in the same authors looking at the data suggested that in 17 years there had been little change. And why? Because medical histories and physicals were still required, meant it was just too easy to continue to order laboratory testing. The routine pre-op medical history and physicals, though, were of little value. So why did cataract patients next receive these physicals and lab tests, even though they were shown not to be cost effective? Next. First of all, there were regulations that insisted on a complete history and physical by the Center for Medicare and Medicaid Services. Stuck with regulations, there was no financial incentive to drop the laboratory testing. Another impediment, as David talked about, is the litigious society in which medicine operates, and the extensive history, physicals, and lab tests are part of defensive medical practice. Next. So where are we now? Well, in 2016, interestingly, the political climate changed. Lots of discussion about that. But one of the things they did was reduce government oversight. And that meant a change in efforts to reduce paperwork as well as government oversight. Successful lobbying by researchers, coupled with the evidence base, convinced the Center for Medicaid and Medicare Services to change their policy. In 2019, the policy became one of physician-directed need for history and physical rather than a mandated history and physical. We are still awaiting data on the effect of change in these regulations, although individual hospitals are instituting change. So in conclusion, I've highlighted some of the challenges in bridging this gap of research to policy. These include powerful adversaries to new or changes in policy, entrenched regulations with a disincentive to alter them, and of course, a political climate which needs to have a taste for policy change. But there are success stories that are characterized by effective, broader partnerships with private industry, government partners, and non-governmental organizations. And critically, research which needs to be directed to sentinel questions and provide the evidence base that supports these policy changes. So that's my take on public health research, trying to bridge this gap to policy challenges and successes. I think we're turning into a discussion now. Thank you for your attention.
Thank you so much, Dr. West. And thanks to all our speakers, Dr. Chang and Dr. Haripriya. So let's open it up for any questions. I do have one question for Dr. Haripriya, and maybe the others can also comment. the Aravind system has done such a terrific job. I mean, it's really the model that I think a lot of us subscribe to see this incredible success story about sustainability. And I know that you all have also worked with other countries and other systems to try to build infrastructure. And I'd love to get your perspective on what you've done outside of India and how successful that's been in order to translate the lessons that you've learned into sustainable systems in other countries and regions.
So that is actually the one arm of Aravind is the advocacy arm. It is part of the work of an organization called LICO. They work with about 300 eye hospitals. That's the number of hospitals they have worked with. And the idea is to work with them to build their capacity. It could range from anything in terms of volumes, in terms of quality, their structure, their financials. So any of these processes, we try to see what is the gap they have in their system and see if anything they can learn from us. So we have a team who comes here and spends some time with us. We have a team which goes there as well. And this kind of cross-learning does help to enhance capacity.
And how successful have you seen that to be in other cultural or regional settings? Right, because
I think it has been largely successful, but in some populations we have found challenges. I know we have had a lot of challenges recently with the large grant from Hilton Foundation. We work with a couple of hospitals in Africa, and the challenges they face there are quite different in terms of human resources, in terms of other aspects. But I think, in spite of all of that, there is something which we can do when we work together to improve the quality of care or the number of patients they can treat. I think the application is, there are some lessons which will be applicable to many populations across the world, is what we feel. You may not be able to take all of it, but I think a lot of it is something which you can apply.
Great. And Dr. Cheng, you have a comment?
Yeah, well, I wanted to follow up with that really good question, because I think LICO is, an amazing organization. It's done a lot that is sort of unsung because they're really lifting up other programs. And I'd pose this to Dr. Haripriya, maybe Tiku, I see, is still on the line. One of the problems that organizations have is retention of physicians and staff. They get trained, they get this highly coveted skill set, and then after a while they leave. So there's no quick answer to this, but have there been any lessons on how to best retain the talent that you train, which is so vital to, again, the sustainability of delivery of services?
Yeah, so I think, that is a good question. That is probably one of the big challenges we face as well, in terms of training, again, having access to resources, to have the right equipment, instruments, and everything in terms of getting consumables in, having the right viscoelastic, IOLs, all of this, the process is quite cumbersome. So which makes training itself that much more difficult. And once they are trained, how do you retain them and how do you make them good trainers and have it as a more self-sustaining system? That's the other challenge which we have also felt in the past.
I think one other challenge that was faced, particularly with the Africa project, was just the population itself. When 80% are rural and spread out in relatively small villages, then the delivery of eye care services in that kind of setting is very different than one in which villages, typically in India, are much larger and can support those kinds of efforts. So I know the challenge of trying to bring eye care services into very rural, very spread out populations is it's a real challenge when 80% of your population may be rural.
Yeah, that's a great point, Dr. West. And it kind of bridged to the next question of recognizing that there are local differences. And these local differences can be geographic, it can be cultural, but sometimes these differences are country policies. So from your opinion, talking about bridging what is research and what is recommendation by the WHO into the country and district level, how does one unified recommendation from the WHO maybe doesn't quite work for all the different countries based on their local policies?
Now that is a really good question. And if I can use an example that I showed in my talk, was the trichiasis manual on how to perform surgery. And in that is the certification for surgeons under the presumption that you can take an eye care professional like an eye nurse, like an integrated eye care worker in the case of Ethiopia, and train them to be good trichiasis surgeons. But the implementation of that across countries was very much hampered by regulations that said only ophthalmologists could deliver surgery to, in this case, to correct inturned eyelids. And when you don't have enough ophthalmologists in country, that becomes an immediate barrier to getting trichiasis surgery. So sometimes in-country policies affect the ability to bring public health approaches, and for reasons that are sometimes seen as self-serving rather than really enabling us to tackle a problem. I know that there's a lot of interest in the American Academy on proficiency-based testing rather than on particular degrees for carrying out certain tasks. And I would urge that as a way forward, and as an example that then helps us with other countries in implementing policies that are maybe more proficiency based.
Yeah, we can definitely do a deep dive into that about training models and competency by design, which I think is a hot topic in the education sphere. But kind of sticking with the concept of policy and David, Dr. Chan, you mentioned earlier about how we have ample research to prove or to show that some of the infection control mechanism that we have in place may not be necessary. It may be a bit of a overkill, but at the same time, how do you think we can change the large system of accreditation, hospital accreditation, operating room accreditation, to go the other direction, recognizing we're in this sphere of litigious society that is becoming even more and more litigious since COVID, I believe?
It's complicated, and again, I will refer to this editorial that was published last week where I really try to tackle what it's going to take. I really don't think liability is the number one thing, because again, the surveys clearly show that people feel it's, I was surprised 2/3 feel that it's okay to not change your gown in between cases, which I think is true. We have a clean procedure, but I think it's really, I think the most inroads have to be made with the manufacturing side and the regulatory side. And the manufacturing side, yes, they do have a profit motive. Yes, I think they're scared that we're gonna ask them for reusable phaco cassettes because that's gonna cut into their profit. But unlike the tobacco industry, they have multiple ways to make their profits. And they're not just limited to reusable or disposable cassettes. And one of the things that we've learned is they are really creatively looking at ways to reduce the environmental impact of their packaging as well as devices. But then we find out that, especially with the FDA and the European equivalent, it turns out that if you change the packaging, you make it better, you reduce the weight, the plastic, you may have to revalidate and restudy that it didn't change the efficacy and safety of the device, which is ridiculous. And so I think we have to approach, I think medical societies have to, as a neutral party, approach people like the FDA and say, look, people want to do the responsible thing, get out of the way, facilitate it, encourage it, instead of this punitive system where, you're going to penalize any little change. And what we hope happens with iSustain is that we have to really collectively speak as professional ophthalmologists on a global level and say, you know, this is ridiculous. You know, we have to provide the evidence. But I think when I look at what is the evidence on the other side that you need to do this, this, and this, and this, it's really a few experts that are not ophthalmologists. That again, I gave the example, they may be at the CDC or AORN, and they're trying to come up with broad guidelines to apply to all of surgery. And so we have to have our own, we have to develop guidelines that are specific to ophthalmology because our procedure is so different. And the data that we have from Erevin is so compelling, showing that if we eliminated and started reusing all these things, what would happen? Nothing. You know, and I think so we have some advantages. We have the fact that our specialty is a clean procedure. We don't have this risk of cross-contamination, and COVID forced us to prove that to ourselves. Second, we have the advantage that we have such high volume. So even smaller, relatively small things like going from paper to electronic IFU will actually make a difference. You know, when we have 4.5 million IOL boxes opened up every year, that the size of the box is actually dictated by the folded paper pamphlet that I showed. That's why the box has to be that large. But our volume makes these efforts, you know, worthwhile. You know, and then finally, we have this advantage of what Erevin has done, which is again given us a lesson in responsible use of resources without compromising safety. So we don't have to guess will this work. We have to just collectively act on it. But I think it's going to take professional societies in conjunction doing that. We certainly need more research. We're looking. There's some research projects in conjunction with Erevin, culturing things after they've been reused. You know, we have a project to culture gowns after surgery to see if they're contaminated or not. Because if you could show that and get a position statement like what we did with drugs, wow, that would be huge in terms of global waste. And so I think finally, whereas historically it's been about cost, you know, I think Sheila gave the excellent example of Oliver Shine's study at Hopkins, and it was sort of, okay, is there a price on safety? You know, no, we can't be cost conscious when it comes to safety. We got to do an EKG on everybody. But finally, in addition to cost now, we have this indirect way that we are actually harming the public health through these wasteful practices that are unproven. So it's not just about cost and we can afford it. This is again about us all sharing the same problem with climate change. And we developed iSustain particularly as a platform for the younger generation. You know, my generation is not going to have to deal with this anywhere near as long as people that are early career ophthalmologists, where the bulk of their career is going to be dealing with the health impact of climate change.
Yeah, I love, Dr. Chen, how you are very thoughtful in looking at every aspect when considering a problem, and even diving into the size of a box for the IOL implant and how that adds to waste as well. Which, you know, I think as public health practitioners on this call, we often think about unintended consequence of our action, which also makes me think about, you know, pulling Dr. Frick into the discussion here. You know, we're talking about cutting waste and cutting production and reusing products. And, you know, I wonder, you know, if you know of any maybe parallel scenarios from an economic standpoint. You know, will we be impacting industry though? Will we be causing, you know, significant harm to the pharmaceutical industry that we rely so much on as well for innovation? Like, is this going to really impact their R&D and development of drug and innovation in other sphere?
I don't know that there's a direct comparison that's easy to make. I think there's plenty of opportunities still for the pharmaceutical industry to make enough profit to drive future research that, this is important, but it shouldn't be a rate limiting step for their ability to continue to make a contribution. So have to give a little bit more thought beyond that, but that would be my first thoughts on that one.
Can I ask a question of David then? I think the idea of going to the FDA, going to policymakers with the data is a good one. What do you see as the challenges in taking the associations like the AAO and others? It has not been my impression that the FDA or other regulatory agencies have been very welcoming, to say the least, of change. But perhaps in this climate and with this political climate we currently have, at least for the next 2 years, is this an opportune time to do that?
That's a really great question. I mean, I think at the foundation of all of this is it's human nature to be reactionary. And, we react to a banking crisis where there's going to be more banking regulations, and we react to an infection that's blamed on reuse of something. Okay, we got to throw everything out. And that's the whole bias view that is, not evidence-based. I think one of the more insidious regulatory things is that back in 2009, prior to 2009, there would be guidelines, but we were, facilities could develop their own policies and procedures to follow. And it would be based on, for us, okay, we only do eye cases, or, this is our community. And, but then in 2009, what changed is a lot of funding for regulatory oversight of ambulatory surgery centers, and CMS now taking sort of recommendations or advice given by AORN and saying, this now is mandatory, you have to follow it. You have to adhere to everything in that IFU because everything you do has to be proven. And of course, the paradox is we can practice off-label. I can use a drug that's never been proven for a purpose to do this. I can take an IOL. It's never been proven that you can anchor it to the sclera and tunnel it through the sclera and burn the tips. We call that the Imani procedure, and it's a complete paradox. So that was probably one of the, if you want one change, it would be go back to how it was prior to 2009. Where, we can trust the health professionals to do what's right and let them use their education, their evidence, their judgment, and the best evidence, rather than to try to, codify into law every single thing so that there could never, ever, ever be a complication. And I think to finally get to your question, Health and Human Services, which oversees Medicare, CMS, came out last year and said, we are concerned about the, equity issues of climate change. And we have to focus on, maintaining the health of, the impact of climate change on our population. And so if that is in fact true, which it is, this is now a good time to look at some of your policies that are creating this problem. And hopefully that creates that openness to look at something that we see as a ridiculous application of regulations.
I love how this is turning into almost a little brainstorming session on how are we going to tackle these big problem of climate change and policy not following following research. Just one other thought came to mind that I'm going to throw it out to all the speakers is, we know a lot of time big industry drive changes, and one of the biggest player, I would say, in healthcare, at least in North America, has been the insurance companies. And we know that they want to cut costs as much as possible. And a lot of these things that you're mentioning, all the three speakers, that help with not only better quality of care, but also more sustainability for our planet, for our environment. I just wonder your thoughts of tackling policy changes from a slightly different sideways angle by convincing the insurance company to start to mandate these, and maybe that would then kind of work backwards to change big bureaucracies like the FDA and some of these other players.
It's an interesting idea as a partnership, for sure. Industry partners can go a long way to help discussions in this realm. But I guess I would defer to Kevin a bit on this as to the likelihood that they would be partners.
It's the predicting whether you can get industry partners is very challenging, as we all know. So it's hard to say. I mean, we've had examples of great partnerships, and some things just never really get started. And so I think it's managing the entire process and using the lessons learned, some of which you talked about and illustrated very well in your talk, Sheila.
Dr. Methenge?
Yeah, thanks, Vivian. I really enjoyed this second session. It's interesting looking at all the evidence, and I think that it's really important that more publications are simplified into language that a lot of people understand, because I am in a region where we're always aspiring to do what's happening elsewhere. And now we recycle, we use gowns, we reuse gloves, we reuse everything, but we aspire to not do that. So it's really important that it's at this stage that we get the evidence to show that, no, keep doing what you're doing. It's actually better for the planet. And I also enjoyed Dr. Arvind's talk, because sometimes we are under pressure to kind of cut and paste models that have worked elsewhere. But our environment is just so different, and it would be great if, when there are some new lessons learned about, why things don't work in new places, that they're also documented and shared, because then we know what to take and what not to, kill ourselves trying to copy.
Yeah, definitely. The publication bias of positive studies is another big issue for us academics. Please go ahead, Dr. Chen.
Well, yeah, I just want to echo Chiku's really good point. I mean, I kind of felt guilty that this is a global forum, and we talked so much about the United States, but as Chiku said, that so many people emulate what we do as needing to be the gold standard, and it's really dangerous, because as you said, as you saw, my talk was, we need to emulate what people in lower low to middle income resource settings are doing to be efficient. And so I think that's really why it is so imperative. We're the model of what not to do. And, one great example of this is actually, I think, happening in India. Maybe Priya would address that, because here they have done all the evidence-based, they look at their evidence, they have all the data from their registry, and yet regulations are increasing in India in a way that are going to constrain model organizations like Irvin. They're going in the wrong direction. And, I think that's a big concern. Maybe Priya could address that.
That's true, David. What you just said was right. So as you said, our regulations are also moving towards what is being recommended in the West. And they're asking us to have one patient view at a time, to have all the patients wear scrubs, change their gown, and single use and things. And we just know that it really doesn't matter. And so we are always lobbying with all the regulations and trying to see if we could actually influence some of what they are saying, because we know that it really doesn't matter, but it's not going to be easy. So I think this effort from both the US and the other countries and India, I think all of this has to be together. I think we all have to work towards this unitedly. That will enable things.
And that's why I think the connection with climate change is so important, because why are these regulations? It's to take you're trying to lower 4 per 10,000 to 2 per 10,000, your infection rate. So, okay, that's in isolation admirable, but the cost to the public health is incalculable in terms of this unsustainable spending and waste. And I think that is the logic that people have to see, that it has to end somewhere, that we can't push to zero while if it means at the same time wasting precious resources that ultimately impact far more people.
Yeah, well, I just also want to add, Dr. Haripriya, that Aravind is such a model. Like, you've heard that from all of these eminent speakers, but we definitely look to you and the whole health system for a lot of innovation that you've created and examples that you've shown us and successes for sure. So just to reiterate what Dr. Chen said, that a lot of times it is reverse engineering. It is us learning from you on being efficient, being resourceful. So I feel like we in the Western world are humbled a lot of times. The more years we are in public health, the more humble we are by what can be created with very little resources. I just want to say thank you again to all the speakers. It has been an incredible sessions, and it's only possible with all of your expertise and amazing contribution with your knowledge and your experiences. And I especially want to say thank you to the American Academies, specifically to those that have been behind the scene that participants don't get to hear from, Jane Aguilera and Anna Marie Hastings, who are instrumental team members at the American Academy that made this session possible. And thank you so much, everyone, for attending on a holiday Friday and contributing to such lively discussion. We're really looking forward to having this recording shared widely with the American Academy, as well as with any organization that may want to show this to their trainees or show this to their institution partners. With that, I will thank you all. And of course, thank you to Dr. Martin and the team at CUGH for helping make this possible.
Thank you, Vivian.
Thank you, Vivian.
Thanks very much.